Hello everybody. Over the next few minutes we will discuss how we might team up with AI software to deliver the benefits for patients that we all want to do. Now, before we start the discussion, let's talk about what we do currently. So as you know, currently we use an MRI scan which is analyzed by radiologists, and that feeds through to the urologist in an MDT situation where a biopsy decision is made. This is usually done by a single radiologist, and the MDT uses clinical metadata, PSA density, family history, that sort of thing, to decide on the need for biopsy. Okay, so what are the limitations for doing it this way? Well, we know that sensitivity is very much dependent on expertise of the radiologist. The positive predictive value is not great. It's about 50% on average. This is a time-intensive way of reporting MRI scans because radiologists have to assess every case, and there's a lack of prioritization. In other words, we don't know which are the cases that require immediate attention from those cases that are negative that you could leave for later on. And I just wanted to illustrate some of the limitations with this case. So a 70-year-old man, you can see by the arrow that there is a PIRADS4 lesion at the right base, and correctly so. The radiologist also sees a polyp, and you can see the polyp here in the rectum, and then the radiologist stops there. What the radiologist fails to see is the lesion at the left apex. That lesion is a PIRADS3 lesion. You can see that it is hypo-intense on the ADC map, but it is not hyper-intense on the high B value, but it is contrast enhancing, which turned out to be a Gleason 3+4 cancer. Now, had the radiologist had an AI, that lesion at the apex would have been spotted, and that margin that's positive at prostatectomy would have been avoided. And you can see this benefit of using an AI to detect an abnormality that a radiologist may miss in clinical practice. This is not a surprising result, because if you look at the PCa challenge, and everybody hopefully has read this paper in Lancet Oncology in 2024, the study clearly shows that the AI can be very helpful against 62 radiologists on average performing better. The reader study will show that it helps less experienced radiologists more than experienced radiologists. The important thing is that the AI's performance does not exceed that of the original reporting radiologists for those cases. So these radiologists were working on their own machines, using their own PAC systems, and had clinical metadata working within MDT, so it's not surprising that the original radiologists are not beaten by the AI. So what we can say is that the AI shows promise as a standalone reader against single readers, but its performance does not exceed expert readers, and two, that this AI is currently untested against a multi-reader situation. So for example, in screening you might have more than one reader. Do we know whether this AI would exceed the performance? I would think not. So what we're saying is we need some sort of collaborative models to ensure that we maximize the benefit of using the AI and to ensure accurate diagnoses. Now there's several ways that you can use AI in your routine practice. The standard of care, of course, is no AI. Well, one of the things we could do is get rid of the radiologist. Now, if the MRI is read by an AI and that feeds directly into the MDT, what would be the consequence of that? Well, it would certainly provide efficiency. It would get rid of the radiologist. The human costs would be removed. And it's potentially suitable if you have no expertise in reading prostate MRI scans. However, this would require a very high level of performance to engender trust and validation, but it raises significant ethical concerns and legal concerns also, which is why it is not currently recommended. Another thing we can try is to use AI for radiological decision support. So in other words, in this particular instance, the AI is giving its own predictions to the radiologist, who makes that final recommendation to the MDT and urologist about the need for a biopsy. This can be helpful for inexperienced users. The AI output should clearly be simple, clear, and actionable for the radiologist to use, and the radiologist should understand the limitations of the AI so as to use the information appropriately. Now, it turns out that this will help inexperienced radiologists the most, which is something we just mentioned before this. So, and here's some data. So on the bottom right, you can see inexperienced radiologists being helped by this particular AI. The experienced radiologists on the top right being less helped by the AI, but you can see that the inexperienced radiologists with the AI, their performance is almost as good as the experienced radiologist without the AI. So in other words, it can help raise that performance of less experienced radiologists. But there is a problem here. And the problem is over-reliance of the radiologist on the AI. And this is something called automation bias. And I just want to show you an example of automation bias. So here's a man, 74-year-old. Brother had prostate cancer at an older age, so not a strong family history. And this should have been called negative, but it wasn't called negative, it was called positive because of the AI. The AI highlights a number of abnormalities, you can see there, in the peripheral zone and in the transition zone, and this was then called positive. The consequence of calling this positive was 27 biopsy cores, all of which were negative. A nice example of automation bias affecting the radiologist in this particular instance. So another model might be to use AI as a second reader. So the AI is not whispering this time into the radiological ear, but is feeding directly into the MDT. So the MDT is getting two opinions, one from the radiologist and one from the AI. So in other words, we're using the AI in this particular instance to overcome some of the limitations of the radiologist. In other words, it's acting like a safety net. So in this particular instance, the AI's sensitivity should be set higher for the MDT to consider with the radiological input also occurring. But in this particular instance, it's important for the MDT or the biopsying urologist to critically consider the fact that the sensitivity has been set higher, because there may be an MDT automation bias, and I just wanted to illustrate that next. So here's an AI that was used prospectively. You can see that the radiologists in 245 men identified 323 PIRADS 3 to 5 lesions for biopsy. Okay. The AI, which was also used in parallel, identified 520 lesions, but didn't give a suspicion level. Okay, so it says these areas look abnormal to it. Okay, what was the consequence of that? The consequence was that there were 4% more clinically significant cancers detected in these men. Okay, and there were more clinically significant lesions also detected. Okay, these are on the plus side. On the other side, the number of target lesions increased by 54%. So the radiological targets were 336, the biopsied deep learning targets were 518, right? So huge increase. And therefore, the number of false positive lesions per case also more than doubled, from 0.66 to 1.39. So that's the flip side. So too many lesions were being seen. For example, this particular case. You can see in this particular instance, there's a lesion in the left peripheral zone, which the radiologist will call normal, which the AI says, look at this case, but doesn't give a suspicion level. It just says, look here. Okay. And if the urologist biopsies that area, this leads to the increased number of false positive lesions per case. Another way you could use the AI is as a triage. So in this particular instance, the AI looks at the MRI first and says, this case is negative. If it calls a case completely negative, you can see the patient can be sent back to his general practitioner for follow-up. If the AI is not certain, or if it's positive, then it may be then referred to a radiologist to analyze, and then to the urological MDT, where a biopsy decision is made. Now, this is clearly a way of optimizing resources, because many other negative cases will then disappear, and this could be between 30 and 50% of all the cases, which is a good thing. Of course, the performance of the pathway will really depend on how this part of the pathway is performing. In other words, the rule out ability will directly affect the performance of this pathway. So the criteria for triaging these negative cases needs to be very carefully defined. The last way we can use an AI is as a high confidence filtering system. Confidence in positive cases and confidence in negative cases. So if you are very confident, if the AI is very confident that the patient has a cancer that goes directly to the urological MDT for a biopsy decision, if the AI is very confident that there is nothing there and the patient can be discharged, as in the previous scenario, and the radiologist with the AI then determines the indeterminate cases. Now, of course, this can significantly reduce workload and efficiency. However, the performance of this has to be the highest, because there's a greater degree of autonomy that you are giving to the AI. So in other words, the rule in and the rule out ability has to be at a very high level. So this is when we can start to discuss what the performance requirements are for AI systems within these different human-AI interaction scenarios. So what are the rule in and the rule out performance requirements for all these scenarios? Now, of course, if you're going to use an AI as a standalone, well, that has to have the highest performance. But we've already said that we are going to discourage that because AIs should augment and not replace human expertise. The general point that we should make right now is that the greater the degree of autonomy, the greater is the performance requirement for the AI. So if you talk about the AI whispering into the ear of the radiologist, i.e. decision support, or as a second reader, feeding back to the MDT as a secondary reader, then the performance has to be set so that it gives you a higher sensitivity. So you want all the lesions to be shown to the radiologist or the MDT, who can then decide which lesions to biopsy, etc. And remember, there is a chance for automation bias to the radiologist for decision support and to the MDT or the urologist as an additional reader. And I've shown you the data on that. If you were to use the triage method, remember, the higher level performance should be on ruling out cancers in those patients who are going to be discharged to the to primary care. So the rule out performance has to be greater, and rule out performance means high sensitivity and a high negative predictive value. If you are going to use it for filtering purposes, high confidence filtering on the positive side and the negative side, then you have to have even higher performance standards. So you can see how the performance standards very much depend on the scenario that you expect to use. So we've talked about positive interactions between the radiologist and the AI to deliver benefits in terms of performance and in terms of time efficiency. We've also said that training of the radiologists and educating urologists and MDTs is going to be critical if you are to overcome this issue of automation bias. And remember, automation bias is an example of a negative interaction. So a negative interaction follows an inaccurate AI prediction, but also this automation bias that we also talked about, which really speaks to the need to develop robust and accurate models and then human training on the use of AI systems. So when we start to think about what factors influence the effectiveness of AI assistance, then really number one is accuracy. And as we already said, the accuracy should be commensurate with the pathway being employed or deployed. Okay, so high accuracy is critical for ruling in and ruling out significant disease, to minimize these negative interactions and to maximize, of course, the benefits. And of course, the highest accuracy is reserved for the autonomous use of the AI. Another thing that affects the AI assistant is the experience of the radiologists. The radiologist's familiarity with how the AI performs and how much trust he has on the AI. It's clear that AI is most helpful when there is a greater task complexity. And in fact, AI seems to be most helpful when there's a complex multi-step pattern analysis and reporting task, which is what radiologists have to undertake for prostate cancer diagnosis. So they have to do a number of tasks. You can see glandular localization, segmentations of the lesions and of the gland, classification of individual lesions, trying to eliminate false alarms, doing reporting. So these are a number of things that the radiologists have to do, and then make a final recommendation based on the PSA, density, etc. What are the best ways of biopsying? So these are complex tasks that have to occur one after the other, and for that kind of application, an AI can be very useful. Now, there are, in fact, ethical implications in each of these scenarios. I'm not going to go through these in very much detail. I'm just leaving these up here for you to look at. But I did want to consider two things. One, whether it is ethical not to use an AI if one is available. Now, if you don't use an AI, then what you do is you maintain the status quo. In other words, you perpetuate the limitations that are already there. In other words, interradial variability, potential for miscancers, unnecessary biopsies, and this will directly impact patient care. Number two, it will only exacerbate workload challenges. We know the workload is increasing, and if we do not respond by deploying AI, potentially there is a problem which could result in radiological burnout and delays in diagnosis. You also disadvantage the healthcare system and your patient by limiting access to expertise that AI could bring to the table. And overall, you could hinder advancements in prostate cancer care. We also talked about the ethics of using AI alone. And these relate to accountability, trust, and of course, dehumanization by taking the radiologist out of this process. So there are a number of general ethical things that we need to think about. As we said, failure to leverage the advantages of AI, human oversight of the diagnostic process. Of course, you need to have thorough validation. You need to make sure that your radiologists are well trained so that they can effectively interpret and interrogate what the AI is saying. We must make sure that AIs overcome potential biases, that they're not only trained on a particular racial group, but a diversity of racial groups, different prevalences, and of course there has to be clear communication between the diagnostic team and patients about the fact that AI was used for making their diagnosis. So finally, let's just bring this all together. There is no doubt that human-AI collaboration is going to be key to unlocking the full potential of MRI in prostate cancer diagnosis, because it will improve detection, reduce variability, is valuable for inexperienced users, and can reduce the number of biopsies. Okay. We are now aware that AI can also improve workflow efficiency, particularly in the triage and filtering scenarios that we just talked about. Clearly, there needs to be benchmarking metrics for ruling in and ruling out clinically significant disease for all the radiological scenarios, but especially for the AI triage pathway and the confidence filtering scenarios. Finally, we need to do some prospective studies to evaluate the impact of these radiological scenarios in prospective clinical trials, where we can then actually measure things like time efficiency gains, how the AI would perform across a diverse population cohorts, and in real life situations where the image quality may not be great. I hope that you found some of these comments useful as you think about how you might yourself begin to integrate AI into your own practice. Thank you very much for listening.